We are very pleased to welcome Dr. Patrick Jung, who is a PGY Ford Geriatric Medicine at the University of Toronto. Dr. Jung completed his, Dr. Jung completed his internal medicine residency at the University of Toronto and his undergraduate medical education at the University of Manitoba. Before we get started, I'd like to let you know how to engage with the speaker today. Please use our chat box and type any questions that you have, and we'll answer them at the end of the presentation. One common question is, can we have a copy of the slides and video for the webinar? Yes, you can. We'll send them to attendees at the end of the presentation, and they'll be on our website. And with that, I'd like to invite Dr. Jung to take the stage.
Thank you very much, Wendy. All right, so hopefully everybody can see my slides. And okay, so thank you again for the introduction, and thanks very much for the opportunity. I thought today I'd discuss a topic that most of us address on a daily basis, really, and provide a bit of a review as well as update of some of the more recent literature regarding management of hypertension in older adults. So I have no conflicts of interest to disclose. And then with respect to my objectives, so certainly by the end of the session, I hope to have reminded you of the burden of disease of hypertension. Hopefully we'll be a little more familiar with the current guidelines from Hypertension Canada. We won't have time to go through all of them, but certainly we'll focus on a couple, and particularly hope to point out the underlying evidence supporting some of those recommendations from Hypertension Canada. And then lastly, hope to recognize the unique considerations in managing hypertension in older adults. So to start off, I just wanted to get a sense of who's in the audience today. So if you don't mind answering this poll. Terrific, thank you. So lots of nurses, a few physicians, a good variety, and others. Well, great. Okay, thanks so much. So again, thanks for tuning in. Next poll is just your best estimate to the prevalence of hypertension in adults over age 65 in the United States, please. Perfect. So majority is right on. This is from a 2018 US American Heart Association stat, but 75% of adults over the age of 65, which I think is quite remarkable. Obviously, we have a bit of a bias where in hospital, almost everybody seems to have hypertension, but to think 3 in 4 of all older adults have hypertension is quite remarkable. And so these numbers are from Hypertension Canada as well as the Heart and Stroke Foundation as of 2016. And hypertension is the leading cause of death and disability in our country. #1 reason for physician visits, accounting for over 20 million visits annually. It's the #1 indication for prescription medications, accounting for over 80 million prescriptions annually. And it's thought to cost our healthcare system about $13 billion per year. And by 2020, which is just next year, predicted to have increased to $20 billion per year. And then this is just a quick reminder that the Hypertension Canada as well as American guidelines all explicitly describe how blood pressure should be managed because really so many decisions are being made on these readings. And so just as you see in the photo, we always like to have the patient in a seated position, back supported, feet flat on the ground, arms supported, resting for 5 minutes prior to the measurements. And for in-office measurements, the automated office blood pressure is the preferred method, whereby you you measure initially, and then you leave the room, and then the remainder of the readings are averaged out to give you a final value. And so this, the first take-home message really is not surprising to anybody, just to, again, recognize that hypertension in older adults is very common, has a substantial impact on morbidity, mortality, and economic costs. So I'd like to introduce a case very similar to a patient that I met in my longitudinal clinic, and hopefully it'll help us illustrate some of the points as we go on today. But Mrs. H, 82-year-old female, referred for cognitive impairment. Quite well, her only medical history consisting of hypertension, dyslipidemia, and osteoarthritis, for which she'd undergone a right total knee arthroplasty. Medications, fairly simple really for our population, but hydrochlorothiazide, 12.5 milligrams a day, and then a statin at bedtime. Living alone with her apartment, living in an apartment with her husband, and quite functional, independent with all of her ADLs and IDLs, not receiving any community supports. And then this was her blood pressure measurement. I realized I didn't include the sitting value, and I just emphasized that it should be in a sitting position, but supine standing, just wanted to illustrate no orthostatic drop there. When we did a Montreal Cognitive Assessment, scored quite well, 27 and a 30. And in terms of her examination as well as investigations, nothing remarkable. So the next poll was just to get a sense of whether you were satisfied with her blood pressure control, as is. Great. So majority happy with the blood pressure control that we've achieved so far. And so Hypertension Canada actually, as I'm sure many are very familiar, divides their guidelines into various different indications. For example, individuals with hypertension and diabetes, or hypertension and heart failure, or hypertension and chronic kidney disease, so on and so forth. Again, we won't have time to go through all of them, so I thought I would focus on really isolated hypertension. This is a particular guideline. So for high-risk patients, and we'll get to how they define that, aged at least 50 years or older, systolic blood pressure greater or equal to 130 millimeters of mercury. Hypertension Canada suggests that intensive management to target systolic blood pressure less than or equal to 120 millimeters of mercury should be considered. And furthermore, they do state that patient selection is recommended, and caution should be taken in certain high-risk groups. So who qualifies as a high-risk individual? So they outline 4 criteria, and which include the clinical or subclinical cardiovascular disease, chronic kidney disease with EGFR of 60 or less, though not so severe, so not below 20. Your estimated 10-year cardiovascular risk, so that's your Framingham risk score greater or equal to 15%. And then really most relevant to us, all of those are relevant, but you see that age greater or equal to 75 years in and of itself qualifies you as a high-risk adult patient. And so next screen there is when should you be more selective, and when should you be cautious. And so Hypertension Canada outlines that there is limited evidence in limited or inconclusive evidence in various different situations, including heart failure, recent myocardial infarction, individuals with diabetes or previous stroke, or EGFR approaching end stage, and then if they are institutionalized, living in a long-term care facility, as well as some other contraindications that they identify if they are unwilling or unable to adhere to multiple medications, if their standing blood pressure has a systolic less than 110, if you cannot accurately measure their systolic blood pressure, or if they have a known secondary cause of hypertension. And so, again, this will be familiar to many, but if you're wondering where those criteria and exceptions are coming from, there obviously have been many landmark studies looking at hypertension management, including in older adults. But in 2015, the SPRINT, the systolic blood pressure intensive intervention trial, published their main study in the New England Journal. And as you can see, we won't go through the nitty gritty of the trial itself, but if you look at the population that they looked at, you'll see that it looks quite familiar. So really Hypertension Canada adopted the same criteria that identified patients to be at increased risk of cardiovascular disease in the SPRINT study, and really word for word took those criteria. And then if you look at who was excluded from the SPRINT study, again, many of these criteria will look familiar because they're the same cautions and contraindications that Hypertension Canada has adopted. And so, why was SPRINT taken up so well? And really, I think it comes down to the fact that their findings were quite significant and quite substantial. So, when they compared intensive blood pressure control, which was targeting, or which was getting a systolic blood pressure to less than or equal to 120 millimeters of mercury, compared to standard control, which was less than or equal to 140 millimeters of mercury, they found that the intensive group had reduced rates of heart attacks, strokes, heart failure, decompensation, death from cardiovascular comorbidities, and really all-cause mortality as well. Now, it came with adverse effects or side effects, of course, and so the SPRINT study also acknowledged that there were, within that intensive group, also higher rates of adverse events, and specifically more episodes of hypotension, syncope, acute kidney injury, and electrolyte abnormalities, specifically being either hyperkalemia or hyponatremia. And if you look through the numbers needed to treat for benefits tend to be in the approximately 50 to 60 range. All-cause mortality, for example, the number needed to treat was around 64, whereas the number needed to harm for the adverse events tends to be in the 40s. So on the whole, you might wonder, why are you going ahead with the treatments? But of course, the outcomes, the benefits were such hard, important outcomes of major cardiovascular events and mortality that in this select population of patients, the thought is the benefit can outweigh the risk. And so coming back to our case with Mrs. H, if you look through her baseline characteristics, she really fits the SPRINT population fairly well. She's over the age of 75, so again, automatically qualifies as a high-risk individual. She doesn't have some of those comorbidities that would exclude her, so no history of stroke, diabetes. She's from home, not institutionalized. Her standing blood pressure was not below 110 millimeters of mercury, and so again, going by Hypertension Canada's guideline for isolated hypertension, she would meet consideration for more intensive treatments. So for a systolic blood pressure less than or equal to 120 millimeters of mercury. Again, always this is with the discussion, obviously, so the patient is aware that we're weighing the risks and benefits, and we know that there are increased risks of low blood pressure, syncope, kidney injury, and electrolyte abnormalities. So the next bit is, if you recall, Ms. H was referred to us initially because of cognitive impairments. So the next question that comes up is, okay, if we decide to control or manage her blood pressure more stringently, how will that impact her cognition? And so there have been several studies in the past, and the evidence was somewhat mixed in terms of kind of two different plausible outcomes. One was the thought that if you can control blood pressure more intensely, then obviously you can reduce the risk of some cardiovascular outcomes such as stroke, as well as reduce the potential harm that comes from hypertension directly. So let's say damage to the small vessels of your brain. And so there's a thought that maybe that would actually lead to better cognitive outcomes. So lower rates of cognitive impairment, mild cognitive impairment, or dementia. The flip side was some thought it was plausible that if you drove the blood pressure down too far, then patients would be experiencing episodes of hypotension, or not necessarily hypotension, but hypoperfusion of their brain. And as a result, that over time could also be traumatic and lead to injury, thus increasing your risk of cognitive impairment. And so this year, in January of 2019, there was another study published, this time in the Journal of American Medical Association, that was really an offshoot of the SPRINT study. And so it was pre-planned. It was the same population, except that and they underwent the same intervention versus control, but the outcome was specifically focused on cognition. And so their primary outcome was what they called probable dementia. Their secondary outcome was either mild cognitive impairment or a composite of mild cognitive impairment and probable dementia. And again, won't go through all the details, but in terms of how they assess for dementia, there were approximately just over 9,000 patients randomized to the two different arms, and they all underwent cognitive assessments by trained individuals, which included various tests such as the Montreal Cognitive Assessment, and then a whole battery of tests. I should say I included some more detail in my slides, so for those interested, you can take a look. But and then they followed the patients. Initially, the plan was for follow-up at the 2-year mark and the 4-year mark, but as you might know, the SPRINT study was terminated early because there was the significant difference in improvement to cardiovascular outcomes in the intervention arm. And so many of the patients didn't actually get to the 4-year assessment. And after the assessment was done, the results were provided to adjudicators who were, my understanding is mostly physicians, either neurologists or geriatricians or psychiatrists, and they were blinded as to which intervention the patient underwent, but they made a determination as to whether or not they thought there was probable dementia versus mild cognitive impairment versus neither versus unable to determine or classify. And so the SPRINT Mind study came with really two results. The first was that in their primary outcome, so they saw that the rates of probable dementia did not differ between the intervention group, so intensive control to systolic blood pressure less than or equal to 120 millimeters of mercury, versus the standard control less than or equal to 140 millimeters of mercury. They did, however, see that there was a statistically significant reduction in MCI, mild cognitive impairment, as well as a composite outcome of MCI and probable dementia in the intensive treatment group. And the authors explicitly noted that the flip side of the argument, the concern that if you drove the blood pressure down too far, that there might be hypoperfusion leading to injury and cognitive impairment, there was no evidence of such negative effect. So the intensive control group did not experience harm with respect to their cognition. And so the authors concluded, again, their primary outcome was probable dementia. So they concluded that intensive versus standard control did not result in a significant reduction in their primary outcome. They did note that, again, this study was terminated earlier. And then we didn't go into all these details, but on the whole, when they looked at the rates of dementia in both groups, it was less than what we typically see in the general population. And so there was a question of whether the study was not adequately powered in the first place. And I suspect part of that lower rate of dementia is really because we were excluding so many patients who we might see in the general public. But again, you saw the inclusion-exclusion criteria were quite stringent. And so once again, coming back to the case for Miss H, the only other aspect really to add after the Sprint Mind results would be that sure, she can qualify for intensive control, and likely we can tell the patient that the intensive control would not negatively impact her cognition. Whether or not it would provide benefits is still hard to say, and depends on kind of how you interpret the Sprint Mind results. And so after that section, really, the take-home message. I know this sounds too simple, but really I think the take-home is that there's evidence now that clearly supports that treatment targets should be individualized to each older adult, and so there's we're moving away from the one size fits all and really trying to tailor our treatment target to the person or patient in front of us. Okay, so the next section is if we agree that Miss H qualifies for intensive control, and if because she meets or fits into the Sprint criteria, then how should we go about it? So here's the fourth poll, just asking your thoughts on whether the choice of the antihypertensive medication she's on, the hydrochlorothiazide, is appropriate. Great. So pretty evenly split between the three options. So that's great. So we'll talk about that. So again, fortunately, Hypertension Canada has guidelines on this. And so there are again, depending on the indication, so if they have concurrent chronic kidney disease or concurrent diabetes, the indications or the first-line choices differ. But again, specifically for adults with hypertension without other compelling indications for specific agents, the recommendation is that initial therapy should be with either monotherapy or single pill combination is now first line. And then they go on to explain the various different monotherapy choices that are permitted. I really just highlighted the thiazide-like diuretic aspect of things, because I think perhaps this is just local and a bit of personal bias, but I think we still see hydrochlorothiazide much more than some of the longer-acting diuretics, and there has been several studies now that have looked at the efficacy of, or the effectiveness, I should say, of the longer-acting diuretics, both compared to placebo as well as compared to hydrochlorothiazide. And certainly the meta-analysis listed here noted that both thiazide and thiazide-like diuretics reduced cardiovascular events, stroke, heart failure, but only the thiazide-like diuretics reduced all-cause mortality. And again, in direct head-to-head comparison between chlorthalidone and hydrochlorothiazide, granted it was a small study, chlorthalidone was shown to be more effective at lowering both systolic and diastolic blood pressure. And so that is the official recommendation from Hypertension Canada. And then the second aspect is, I think, one that we're quite familiar with dealing with or managing our population, and that's based on the principle of trying to reduce pill burden and trying to increase medication adherence as best as possible. So single pill combinations now, there are several available here in Canada, and they are first-line agents regardless of the severity. So you don't need to be X millimeters of mercury above target in order to use the single pill combination as first-line therapy. The Hypertension Canada guidelines do explicitly recommend one of these three options, either being ACE inhibitor plus a calcium channel blocker, an angiotensin receptor blocker, and a calcium channel blocker, or ACE ARB and a diuretic. And I just listed a couple medications, single pill combination medications that are available here. In the midst of preparing for this presentation, I learned that in the US there's a pill that actually combines three different medications, amlodipine, olmesartan, and hydrochlorothiazide. Chlorthalidone. Is that one? No, sorry. It is hydrochlorothiazide. And I don't think it's yet available here in Canada, as far as I can tell. And again, the rationale behind this, really, it's plausible, and again, they've been able to demonstrate that single pill combinations are associated with better adherence. Again, not surprising. And furthermore, with the better adherence, the regimen with initial single pill combination has led to better blood pressure control, which is the ultimate target here. It's just fun, but there are lots of medical professionals on Twitter, and I thought this tweet was funny, mostly lamenting the fact that chlorthalidone is not available in a combination pill at present. I think this gentleman, Dr. Joltoff, is a nephrologist who's quite prolific in terms of education and education through social media. So the take-home message here, again, not to make it sound too simple, but really the importance of considering both effectiveness as well as ease of adherence. And this point, obviously, one that we're very familiar with when interacting with the geriatric population. Okay, and then the very last question now is asking about elevated blood pressures in hospital. So if you can imagine that Miss H was admitted to hospital for a wrist fracture, her blood pressure medications are elevated to the 170s systolic, despite what we think is adequate pain control. What do you feel should be done with her antihypertensive medications? So great, much clearer majority here saying we should monitor BP while continuing to address contributing factors. And so I think there is now increasing evidence that that is indeed kind of the preferable route. Obviously, this is different from if the patient has hypertensive urgency or hypertensive emergency, where the blood pressure must be treated. But if that is not the case, there was another study that came out towards the end of last year in the British Medical Journal that specifically looked at the intensification of blood pressure treatment at time of hospital discharge. And so this one examined approximately 15,000 patients, the vast majority of whom were male, and that was strictly because it was through the VA hospitals and their clinics, where predominantly the patients were male. And what they did was, it was a retrospective cohort study. They looked at the patient's prescriptions before they went into hospital for an admission, and all these admissions were for non-cardiac causes. And then they looked at the prescriptions that they were on at time of discharge. And they found that surprisingly 40%, so 1 in 7, ended up having their hypertensive regimen intensified. So either a higher dose of medications that they were already on, or new agents added on compared to pre-admission. And when they dug further, interestingly, there was no difference in who was intensified based on whether they might truly benefit from it, or whether they were likely to benefit from it, or less likely to benefit from it. So, for example, when they looked at subgroups who had a history of cardiovascular disease, who presumably might benefit more from intensive blood pressure control, the rates of intensification at time of discharge wasn't any greater than the subgroup of patients who you might expect may not benefit from more intense control. So individuals who had limited life expectancy, or dementia, or metastatic cancer. And instead, what did make a difference was really just whether or not their inpatient blood pressure was elevated. And so that was the predictor that was most strongly associated with whether or not you had new or higher dose of blood pressure medications at time of discharge. And then they also were able to look back on their pre-admission clinic records and identify whether or not prior to admission, these patients had good control versus poor control of their blood pressure. And then when they separated out into those groups, they again found no relation. So whether your control was good before entering hospital, or poor, was not associated with whether your medication regimen was intensified at time of discharge. So again, the only bits that, or the factor that seemed to matter the most was really just whether or not your inpatient blood pressure was elevated. So the authors concluded that, just quoting them, so more attention needs to be needed. More attention is needed to reduce potentially harmful overtreatment of blood pressure as older adults transition from hospital to home. So again, there were many patients who had well-controlled blood pressure who are now leaving hospital with intensification, simply based on their in-hospital readings. And so the take-home message here is to try to avoid the reflexive intensification of blood pressure medications when patients are admitted to hospital. And there was, in fact, an editorial submitted by some of our attending physicians here in Toronto, Dr. Bell and Dr. Nathan Stahl, who kind of summarized it as saying, essentially, clinicians would be wise to adopt Sin City's famous tagline, "What happens in Vegas stays in Vegas." Often the safest approach to inpatient chronic disease management should be to let what happens in hospital stay in hospital. So I think it's a consideration to keep in the back of your mind. And so that's a summary. This is just kind of the 4 take-home points that I was hoping you would leave with today. So number 1, again, recognizing hypertension in older adults is very common. It has a large impact on morbidity, mortality, and economic costs. Number 2, the treatment targets for hypertension should be individualized. And again, there's evidence for this, particularly in older adults. Number 3, when choosing blood pressure medications, please consider both the effectiveness as well as the ease of adherence, because both do lead to better outcomes. And number 4, as best as possible, if you can avoid reflexive intensification of antihypertensive medications when patients are admitted to hospital. So that's it. Ended a little earlier than I expected, but any questions or comments, I'd be happy to try to answer. Thank you.
Great. Thank you very much, Dr. Jung, for sharing the current research and your expertise on caring for older adults with hypertension. So as mentioned, there's plenty of time now for questions or comments. So we encourage the audience to type in the chat box any questions that you may have or comments for Dr. Jung. And while we wait for people to type their questions, I'll start us off with one. How should primary care providers manage the care for older adults who have experienced reflexive intensification of antihypertensive medications in hospital? Although that's not the preferred method of management, that may happen. So any insights or tips you may have on that transition of somebody who's experienced that might be helpful.
Absolutely. So I think that's a point of a challenging point where again that transition can be a time of vulnerability, and so ideally, of course, when the patient is being discharged, hopefully there's a communication to the primary care provider. Beyond just the discharge summary being faxed to them, where there might be notification that, you know what, we had to increase some of the blood pressure medications. Can you please reassess the same? And I think oftentimes, just due to time and other constraints, that communication might not be possible. So whenever patients are discharged, we almost always advise them to follow up with their primary care physician, as they'll need somebody really quarterbacking their ongoing care. And so I'd suggest, and obviously I'm sure there are many primary care providers who are much more experienced on the receiving end here, but if certainly they can repeat some of the blood pressure measurements in the office setting, again using those recommended methods of automated blood pressure measurements, and essentially reassess as to whether or not the blip in blood pressure was due to the hospital admission, or if indeed something has changed, and so the increased dosage or intensification is required. So I guess beyond reassessing and monitoring from there, I guess that would be my main recommendation.
Great advice. Thank you very much. So I see some questions are starting to come in from the audience. Not everybody can see them because some have come directly to Dr. Jung here in the chat box. The first one is from Anya Martin. Hydrochlorothiazide has been the first choice for years, but now there's a warning about the risk of developing melanoma. What do you think about the use of hydrochlorothiazide as first choice?
Thank you. So I have to be honest, I actually did not realize the risk of developing melanoma with hydrochlorothiazide. I think perhaps and just even more impetus to transition to a long-acting thiazide-like diuretic, whether chlorthalidone or indapamide. And again, apologies, I'd have to look at whether those medications are also associated with the risk of developing melanoma or not. If not, then I think it is just further reason to make the transition.
Okay. Question from Camilla Wong from St. Mike's Hospital. Thanks for a great presentation, Patrick. Often there's reticence among geriatricians to use thiazides like due to risk of light abnormalities and EGFR compromise. I think previous studies have shown about 2% of those over 65 may experience this. How would you advise to evaluate for those who are at most risk?
Great. Thanks, Dr. Wong. I guess really always risk benefit, and it just has to be I would think it just has to be a conscious decision whether or not you'd like to try the thiazide or the thiazide-like medication. Just like you mentioned, there's a risk of, and certainly our older adults at increased risk for the EGFR abnormalities or the light abnormalities. And in terms of evaluating ahead of time whether or not you can predict who might experience such adverse effects versus not, I'm not aware of any particular scoring tools or other clinical tools in that respect. Certainly, I think that just emphasizes the importance of following up closely with, for example, repeat blood work in a week, or repeat creatinine measurements at that time, and ultimately it'll just be a assess and reassess pattern to see whether or not the patient tolerates the same.
Great. So if there are any other questions, please feel free to type them in the chat box. And I'm assuming that from the lack of questions that you've provided actually very comprehensive information here. There was a lot of great detailed information with a wonderful case study that helped people really put the picture together. And I know that I learned a lot from your presentation as well. I got several of the poll questions wrong.
Not at all. You're too kind. Thanks.
So if there are further questions for Dr. Jung, you're welcome to contact us or Dr. Jung directly about the presentation. And I just want to say thank you very much for this great learning opportunity. Also, thank you to everyone who attended the webinar. The attendees will receive a short evaluation survey by email, so please share your suggestions and topics for future webinars with us. And we'd also like to let you know about our upcoming webinar on July 26th, where Dr. Barbara Liu will speak about the Senior Friendly Care Learning Series, which will be launching in early July. Registration information for this webinar will be emailed soon. Oh, before we sign off, I see there's another question has come in from Laurie Phillips. Was there an increase in falls for patients at risk of increased syncope?
Great. So in the sprint, the original sprint study, if that's what we're referring to, surprisingly, there was the increase in syncope, but there was no increase in injurious falls. So that was one of the adverse effects that they explicitly looked for. But fortunately, no increase in injurious falls.
Great. Thanks for that. Okay, I'd say with that, we'll say thank you very much and see everybody next time. And
Great.
We're signing off for now. Thanks again, Dr.
Thank you
Jung.
so much. Thank you. Take care.